My name is Jeremy Bear. I'm a clinical pharmacist at Intermountain Medical Center Emergency Department. I've been in that role for a little over 5 years now. And then Laura McCall is our PGY2 emergency medicine resident. So she's a pharmacist doing advanced training for the next year, and she's going to do the second half of this presentation. Josh asked me to specifically talk to you guys on this topic. At first I was a little reluctant and thought, well, why does he want to talk about overdose on antipsychotics? And as we go through these slides, Laura's got a slide set that makes a little more sense as to why, just because of the frequency that we see these. So with that, we'll just go ahead and get started. So the objectives of this presentation today is to identify the different types of antipsychotic and antidepressant medications, because I think that's very important for you guys going out on the scene to be able to identify that, to have a better understanding, to communicate to us in the emergency department of what we're dealing with. Becomes very, very important for that reason. Not only to be able to identify the drug, but that helps us identify peak levels of when that drug's going to be at its highest concentrations, half-lives, and other things like that. Recognize common signs and symptoms of overdoses of these agents. Again, we'll just go through some toxidromes that correlate with these overdoses, and then understand the interventions that can be made by you guys in the field, which can be very important in many overdoses as well. And with this, I'm very laid-back kind of guy, so if you guys want to ask questions as we go, I'm fine with that, or we can hold them to the end, whichever you guys prefer. So when I think of schizophrenia, this is kind of what I picture. I want to be sensitive to this population, just because I can't imagine being in that mindset and not being able to control some of our actions that we do when we have those types of patients. But I just feel like, you've got positive effects of schizophrenia, and you also got negative effects of schizophrenia. And what I mean by that is, with our positive effects, it's more of the hallucinations and delusions and things like that. And I've often thought what it would be like if I could be schizophrenic and have those positive effects for about 10 minutes, just to know what they're going through. And I imagine it would be very interesting, to say the least. Where the negative effects are things that I absolutely wouldn't want to be dealing with. So a little bit of background with antipsychotics. So prior to 1950, anybody know how we treated schizophrenia? Shock therapy. Or just sedation. Any way we could sedate the patient is how we treated it. At 1950, so we used a lot of barbiturates. So phenobarbital, pentobarbital, all those different types of barbiturates, just to sedate the patient, to try to get them through their episode. And then there was a big paradigm shift in the treatment of schizophrenia that came along just after 1950 in the 1960s. And do I pause or do I keep going? Okay. And that's when we started seeing chlorpromazine and haloperidol. So that is our compazine that this is probably what you're more familiar with, that name. And these things started controlling these positive signs. We were able to treat the positive signs of schizophrenia more effectively with these agents, and it was a big, big breakthrough for schizophrenia. I also want you guys to understand that it's just not schizophrenia that these drugs treat other things, such as refractory migraines and nausea and vomiting. So they have dual roles. So we're not just focusing on schizophrenic patients that have the potential to overdose. It can be some of these other patients as well, as long as they have these types of medications within their reach. So there's two different types of antipsychotics that we have: typical and atypical. Anybody in the room tell me a typical antipsychotic? No, that's more for bipolar mania. So Haldol is a typical antipsychotic. What about an atypical? Okay, Seroquel, Geodon, Abilify, Risperdal. All these are the atypicals that we're probably much more familiar with. And the reason why they got their atypical name, or second generation antipsychotics, is because atypicals have less propensity of causing extrapyramidal side effects, which we'll go into in a little bit. So, like you mentioned, Haldol is a typical antipsychotic, and it's used for various reasons. Like I've mentioned, we use it for sedating a psychotic patient in the ER or in the field for you guys. Do you guys carry Haldol? As well as many other things. We use it sometimes for that refractory migraine, or even to treat some refractory nausea and vomiting. There are a few downfalls to Haldol, and probably the one that you guys are most familiar with is QT prolongation or QRS widening. And with the QT prolongation, we have to be careful with patients that are also on other types of QT prolonging agents. With that, patients that overdose on these types of things have falsely high QTCs. So a lot of times it's much lower than what is actually reading on the EKGs. So like I mentioned, typical antipsychotics are great at controlling the positive things. So positive symptoms such as hallucinations or delusions or those other things that go along with the realm of the positive symptoms. What they're not good at is controlling the negative symptoms, and these negative symptoms are poverty of speech or social neglect or things like that. So all these things, like they don't want to talk, they won't look at you, things of that nature. So there was a big gap in the way that we treated these patients because we could only treat one side of it. When we treated with typical antipsychotics, the problem that we ran into is that there was a high propensity of extrapyramidal side effects. And extrapyramidal side effects go into akathisia, which is agitation, delirium, things like dystonia, where they have muscle rigidity and cramping, and then tardive dyskinesia, which we'll talk about as well. But I don't know if you've ever seen a schizophrenic that's been on typical antipsychotics, by lip smacking and things like that, which is very obvious. So along came the atypical antipsychotics in the 90s, which was a big breakthrough for schizophrenic patients to be treated, because the reason why is we treated both positive and negative symptoms. And with the positive symptoms of schizophrenia, it targets the dopamine 2 receptor. And the dopamine 2 receptor is thought to be what they target for those positive symptoms. But when the atypicals came to be, we started targeting serotonin and some other receptors within the brain and other parts of the body to help with both the positive and the negative symptoms. And with that, we got much less extrapyramidal side effects that we'd run into. And the reason why is it's thought to be the dopamine to muscarinic receptor ratio. And with the atypicals, you have a much lower affinity for dopamine compared to the typicals, and that ratio is more in check, so there's not the issues with extrapyramidal side effects in much lesser degree than there is with the typicals. So I'm not going to completely bore you to death with this slide. This is more just informational, but with the atypical antipsychotics, you'll see on the next slide that, or the 2 slides from now, that we hit many receptors, where with the typical, they were just primarily trying to target dopamine. So this is a little pie chart that shows all of the, or some of the atypical antipsychotics, as well as Haldol on there. So you've got risperidone, and you can see here it identifies the different receptors. So you can see how many receptors we are hitting throughout. And this becomes very important to understand when it comes to overdoses, because if you understand what receptors we're hitting, we'll understand why they're having the symptoms that they're having. So we hit dopamine, serotonin, alpha, and histamine, or the muscarinic receptors. And you can see with the atypicals, there is a kind of a hodgepodge of how those are broken up, and that'll go along with their side effect profiles as well. So this is our typical antipsychotic breakdown, and you can see there's many less receptors that it hits. It does still hit a little bit of serotonin. You have a little alpha and histamine, but not nearly as common as you saw with this group of atypicals. You can see it's much, much broader. So this is just a little reference slide for you guys to understand the differences between the typicals, or identifying the differences between the typicals and the atypicals. On the side, you can see probably the most common ones that you're familiar with is chlorpromazine, which is compazine, Haldol, which you guys use, droperidol, which has been on shortage forever, but I wished we had it because it's amazing for refractory migraines, are probably the most common ones that you'll see, and every once in a while you'll see some thiothexine. The atypicals is what you guys will run into much more commonly with overdoses. You've got your Risperdal, some olanzapine, quetiapine, ziprasidone, aripiprazole are probably the most common atypical antipsychotics. These ones on the bottom are some of the newer agents that are just coming on to the market. So this is a case. A 45-year-old male was found in a park by the lake. Past medical history of schizophrenia. He had multiple suicide attempts of cutting himself, slashing his throat, and also some overdoses in the past of overdosing on pills. The patient was found clothed by the lake, no signs of trauma, but he was deceased at the time. And on him, they found 3 vials or bottles of Risperdal. The first bottle was 186 1 milligram tabs that was filled 3 months prior. The second was 124 tabs of the 1 milligram filled 2 months prior. And the third bottle was 93 tabs filled 1 month prior. So this is a ton of atypical antipsychotic. Excuse me. In 2010, there was reported 4,300 calls directly related to overdoses with atypical or typical antipsychotics. And this is thought to be very underreported. And the reason why, as we get into, is atypical and typical antipsychotic overdoses is fairly safe overdose, if there is not a better way to say it. They're usually not life-threatening. It takes mega doses, like you saw on that case with patients, to be able to cause harm to that magnitude. So the thoughts are is that they're significantly underreported, and the fatality rate of just antipsychotic overdoses is less than about 0.5%. It comes in at about 0.02%. So there's a very small portion of patients that solely take antipsychotic medications that end up dying from them. So this was a prospective study done by Akrai and colleagues that was done in Pennsylvania, Philadelphia in particular, in one of their ERs. And it was a 13-month study. And what they were looking at is what were the major issues that we ran into with atypical antipsychotics and typical antipsychotics. And this one targeted Risperdal or Risperdone, and it had 31 patients that they were able to identify in that 13-month period. 29 were adults and 2 were children. And Risperdone's cases that Risperdone was the sole agent was 15 of those. So about half of those cases were just an antipsychotic by itself. And what they found is the major side effects that we run into with this is lethargy by far. So CNS depression is probably the biggest thing that you guys are going to run into. There is the spasms and dystonia, so that could be classified as one of those extrapyramidal side effects. hypotension, and depending on what agent, quetiapine has a large propensity to cause respiratory depression, and this is where we start getting involved in airway issues with these patients. And then tachycardia and dysrhythmias kind of rounded up the top issues with Risperdal overdoses. The other 16 cases were co-ingestions, and this is where we start to get into trouble with these patients, because most of the time, at least 50% of the time, as you can see from this study, is they have other agents on board. And with all overdoses, co-ingestions is where we start to get in trouble. Just like with benzodiazepines, it's fairly benign overdose, and then when you add alcohol or some other agents on board, they become life-threatening really quick. And it kind of holds true for antipsychotics as well. So of these 16 cases, we had benzodiazepines, SSRIs, which is antidepressant, ethanol, TCAs, which is an antidepressant, which Laura is going to go into, lithium, anticonvulsants, diphenhydramine, and ibuprofen were also on board with these patients. And then the breakdown of the major side effects that came along with this is they had a higher risk of lethargy, or that CNS depression. One went into a coma. One had a seizure. We had some tachycardia and bradycardia, hypotension, and one of these patients died that co-ingested a TCA, which Laura is going to give us a better understanding of why in the second half of this presentation. So you can see that this is where we really start getting into trouble with these patients in the field, is when they have other medications on board. So again, very important to identify what they've ingested, and I'm preaching to the choir because you guys all know that. So with overdose, our toxidrome for atypical antipsychotics kind of is a hodgepodge of toxidromes. And the reason why is in my mind, it probably most closely mimics an anticholinergic toxidrome, just because it's hitting the muscarinic and anticholinergic histamine receptors, because you got the tachycardia, dry mouth, flushed skin, urinary retention, dry as a bone, mad as a hatter, all those things that come along with anticholinergics. But you also have some other toxidromes that kind of come into it. Like I said, with the somnolence and coma, their eyes don't fit any toxidrome. You can have pinpoint pupils with it, you can have a normal pupil, and you can have a dilated pupil. So pupils really don't tell us a whole lot in these patients that overdose on this stuff. Agitation can certainly become a problem with these patients, delirium, hallucinations, as well as psychosis. So just to give you guys a little better insight of what extrapyramidal side effects are, is this is a picture of somebody in acute dystonia. So you've got muscle rigidity, you've got muscle clamping down, and can be very painful for these patients. And patients that are in these positions for a long time, rhabdo can become an issue for these patients, which is not a good thing, as well as neuromalignant syndrome. So you can get hyperthermia with this patient population, and it's thought to do with some mitochondria issues in the skeletal muscles, and it's also thought that when we hit that dopamine receptor, that D2 receptor in the hypothalamus, that it resets or changes our internal thermostat. And then you've got acute akathisia, which I talked about, which can be that agitation, delirium, makes these patients very difficult to handle and deal with. So this is the tardive dyskinesia, and this is non-reversible. The extrapyramidal side effects that I just previously mentioned are reversible, and a lot of times those can be reversible with something as simple as diphenhydramine, some Benadryl, or some Cogentin. Tardive dyskinesia cannot be reversed. The good thing with tardive dyskinesia is this is usually not seen in acute overdoses. This is patients that have been on those typical antipsychotics for a long term. So we don't see a ton of this nowadays unless they are managed with both typical and atypical antipsychotics. But this is kind of a classic picture. I've seen this for many years, but it's just that, like I mentioned, those patients that do that lip smacking. Cardiac issues that you guys might run into: hypotension, tachycardia, and the hypotension comes from that alpha receptor that I mentioned. You can get the orthostatic hypotension because it's hitting the alpha receptor. QRS prolongation and torsades is always something on our radar that we see very infrequently, but it can cause some electrolyte abnormalities with potassium and magnesium. So obviously, if we had a patient that went in torsades, some magnesium would be what we'd want to do 2 to 4 grams with. So for you guys, the biggest thing is to identify those potential other co-ingestions. Like we saw in that study, fairly, benign's not the right word, but fairly, I don't know, I'll stick with benign for a bit, lack of a better word, when taken by itself. But when you take it with other co-ingestions such as tricyclic antidepressants, they can become fatal. So identification is a very, very important thing for you guys in the field. Supportive care, obviously, we want to consider activated charcoal if the ingestion's less than 1 hour out, as well as if the CNS depression's so that it's not, they're not being able to protect their airway. Obviously, we're going to give them O's if their oxygen saturation's down below 92 or so. Intubation is rare, but if we need to protect their airway, very important. We don't want these patients aspirating and causing other issues. EKG, we're looking for those cardiac issues, tachycardia, torsades. If their blood pressure is not being maintained because of that pounding of the alpha receptor, crystalloids, obviously normal saline is going to be the first intervention that we do, and that's usually going to fix 99% of these patients. But if it doesn't, vasopressors would then be added, with norepinephrine being the agent of choice. But if you don't carry that, epinephrine would suffice. And then bicarb would be given for those dysrhythmias, and then benzodiazepines would be given for seizures, obviously, but again, very uncommon for this population. So with that, I'm going to transition over to Lara. Is there any questions as far as antipsychotics go that I could address or answer at this point? With that, I'm going to pass the baton over to Lara.
All right, there we go. All right, so I'm going to talk to you today about antidepressants in overdose. So really the three classes that we're going to talk about are SSRIs, SNRIs, and then TCAs. And I'm just going to hold on to this to make it a little bit easier. All right, so let's see. So I just used the down arrow keys. All right, cool. So this is a slide that just kind of indicates our the SSRIs and really just the commonness of how many people are actually on SSRIs. So these are really like the first line agents in treating depression. So you have the Zoloft, the Prozac, Paxil, and things like that. So I really like this slide here because this is an overview of just how many of these overdoses that we're seeing. So this is a report from the 2013 from the American Academy of Poison Control Centers. Across the nation, this is what we're seeing as far as overdose. So with all human exposures, we see sedatives, hypnotics, antipsychotics, and antidepressants making up number 4 and number 5 of the overdoses that we see. So we see, if we look over here, so older children 6 to 12 really don't get into them, younger children don't get into them, but we see them when we start getting into teens. Sedative, hypnotics, antipsychotics here, and antidepressants make up 7% of toxic exposures in teens 13 to 19. And then with adults greater than 19, we see antipsychotics making up about 5%. So again, here's just a list of some common SSRIs. Prozac, Zoloft, Lexapro, I think, are really the biggest ones that we see. So some signs of overdose. So with SSRIs, what they're doing is they're promoting serotonin release into the brain, which helps you feel better. So it makes sense then that the mechanism of toxicity is just all this excess serotonin. So the good thing about SSRIs is they're relatively safe in overdose if they're taken by themselves. So some signs of mild to moderate toxicity could be some agitation, confusion, nausea, vomiting, tremor, and hypertension. Rarely you'll see seizures, so usually maybe 1 to 2%. One of the more severe, syndromes with SSRIs overdoses is a serotonin syndrome. And then you're most likely to see this with overdose of multiple SSRIs or in common with SNRIs or TCAs. And it's really just a clinical diagnosis of serotonin syndrome. So you'd see mental status changes, muscle clonus, agitation, diaphoresis, tremor, and hyperthermia, and muscle rigidity are really your big clues. The good thing about serotonin syndrome is it's treatable if we just discontinue our SSRIs or anything that has that promotes serotonin release in the brain. All right, so this is a study of just some SSRIs and overdose. It's published in the Journal of Toxicology and Clinical Toxicology in 2004, and the title of the article was Relative Toxicity of SSRIs and Overdose. So this was a single-center review. They looked at 469 admissions of patients with SSRI overdose. So the median length of stay was about 15 hours. Only 30 of them were admitted to the ICU. They had about a 2% occurrence of seizures, 2% went into coma, and the serotonin syndrome, 14%. The biggest thing to point out in this study, and it kind of goes along with serotonin with the overdoses of SSRIs, really like the most dangerous SSRI is citalopram. And the reason that is that it causes a QTC prolongation more so than any of the other agents. And they saw this, so 440 is the cutoff for prolonged QTC. And they saw this in about 68% of patients with citalopram. So the treatment for SSRI overdose is pretty straightforward. So mild to moderate overdoses, activated charcoal with large ingestions, and then if they have a seizure, benzodiazepines are your first-line option. In severe cases of SSRI overdose in patients that have serotonin syndrome, there's some evidence that we could use cyproheptadine, but it's not something that you would use in the field. And then, like I mentioned, discontinue all serotonergic agents. So patients that have serotonin syndrome, if we just get rid of their SSRIs, they generally do well. All right, so we'll move into our SNRIs. So the common ones that we see here with SNRIs, venlafaxine and then some Bolte or duloxetine are really our big ones. So SNRIs, so they're fairly similar to the SSRIs and the serotonin reuptake inhibition, but they also work on norepinephrine and dopamine. And dopamine specifically is more with venlafaxine. So the mechanism of toxicity, again, makes sense. So it's an excess of serotonin and norepinephrine. They're typically more dangerous in overdose than SSRIs because they are working on norepinephrine and dopamine. But they do have a similar clinical presentation. So with severe toxicity and large overdoses, we see a lot more hypertension, hypotension, palpitations, and tachycardia. So a lot more cardiac effects with SNRIs. So this is a study from 2008, and they were looking at U.S. poison control centers in 2000 and 2004. So this is a 4-year study. They looked at over 82,000 suicidal single-agent ingestions. And of all of those 82,000, they had 5,000 cases of venlafaxine overdose and 36 cases of duloxetine overdose. So you see a much higher percentage of patients needing ICU, so about 22% with both of those. And they had 12 fatal cases of venlafaxine just by itself, causing fatalities. One thing I liked about this study is it also kind of breaks down some of the age ranges and the gender for these toxicities. So for suicidal antidepressant ingestions, and this also includes SSRIs as well, I really like that it points out that 13 to 19 females are most likely to attempt suicide with antidepressants. And this really, if you think about it, this makes sense because it's generally the age range that we start treating depression, 13, 19-year-old females, and the first-line agents are SSRIs. So you see that it levels off greatly as they get older. All right, so this is just it also kind of breaks down the types of agents that people take by their age group. So tricyclics, tetracyclics, lithium, MAO inhibitors, SNRIs, and SSRIs. So we see SSRIs really peak at the 13 to 19-year-old age range, which again makes sense. So MAO inhibitors are a much older class of drug, and we don't really use them much anymore, but those peaked in age 50 to 59. Or, 40, somewhere between 40 to 50. Okay. All right, so the treatment for SNRI overdoses are really the same as our SSRIs. So we give them benzos if they have seizures, and we give them IV fluids. Severe overdoses, benzodiazepines for seizure and agitation. If they're not responsive to benzos, we would then intubate them to protect airway. Antiemetics are important. And then if they exhibit signs of cardiac arrhythmias, sodium bicarbonate, and then if we have to do ACLS. All right, so now we're going to move into our third class of antidepressants, and these are TCAs, tricyclic antidepressants. So some of the big names that we have, nortriptyline, amitriptyline, and imipramine. So the TCAs are an older class of drugs, and they were really used a lot more before the 1990s when the SSRIs came out. But we've seen the use of them really faded out after the SSRIs. But actually recently we've seen kind of an uptick in the number of TCA prescriptions out there. But the big thing about TCAs is that they're very dangerous in overdose, even by themselves. It's unfortunately common and deadly. So some of the effects, like we talked about earlier, some anticholinergic effects are really the big things. They have effect on serotonin, norepinephrine, and dopamine, so you see an increase in those. CNS depressant has alpha blocking capabilities, and then the big one that can cause the toxicity and the fatalities is the sodium channel blocking, and I'll show you what it does to the heart in a second. So some of the monitoring that we need to do with these patients, the ECG, that's going to be a big thing, and we're watching for specifically QRS widening, and then blood gases as well. So some signs of overdose: mild to moderate, you're going to see your anticholinergic effects, drowsy, sedated, there'll be tachycardic, and then hallucinations as well. With severe toxicity, you see coma, seizures, respiratory depression leading to failure, hypotension, and then cardiac dysrhythmias due to that QRS prolongation. So the treatment, mild to moderate overdoses, consider activated charcoal, and then aggressive supportive care. So with severe toxicities and overdoses, we want to use activated charcoal again. These patients will almost always require intubation to protect the airway. Our first-line agent for treating seizures is benzos, and then you could also consider phenobarbital if it doesn't work. With the widened QRS interval, sodium bicarbonate boluses. And these patients, if they really take a lot of TCAs, they'll require a lot of sodium bicarb. And then a new treatment option, and I'll show you a case report in a second, is IV lipids for these agents. They show signs of hypotension. We start them off with fluids and then go into our vasopressors. So this is a case report. It was reported in 2012 in the Journal of Emergency Medicine of a 36-year-old female who took 30 75 milligram tablets of a TCA called dothapin 2.25 grams 90 minutes before presentation. So she had a pretty serious GCS of 4. Blood pressure was 53/35. Heart rate 130. And then she was severely acidotic with a pH of 6.75, which is not really sustainable with life. So this is what her EKG looked like whenever she presented to the emergency department. So we have a QRS of 154, so very wide QRS, and that's very dangerous for the heart. She had a QTC of 502, which is pretty high as well, and then a heart rate of 130. So this is what they did to treat this patient. So they gave her almost 100 mils of sodium bicarb, and they got her up to 7.08 pH. But unfortunately, at that point, she had a cardiac arrest with a persistent broad complex tachycardia, which is typical of our TCAs. So at that point, they used 100 mils of this 20% lipid emulsion. And this is it's not something that you probably do in the field just yet, but it's becoming more in favor of like a last line agent to help reverse these toxicities. So they had a good effect with this, and they were able to bring her back, continuously giving her bicarb. So 250 mils of bicarb so that's a lot. And this is one of those cases that we'd actually use like a lot of bicarb and start them on a bicarb drip. So this is a summary slide of kind of what we talked about with antidepressants. So the number of prescriptions for antidepressants, SSRIs, then SNRIs, then TCAs are what you're going to see the most. As far as danger of overdose, TCAs greatly outweigh any of them, then probably SNRIs over SSRIs. Like Jeremy mentioned earlier, we should always consider co-ingestants. And then finally, benzos, bicarb, and supportive care are going to be your cornerstones for treatment. Okay, I think that's all we have. Are there any questions that I can answer for you this time about antidepressant overdoses?